see that, can you, Lauren?
Yeah, we can see it.
Okay, perfect. Okay, so hi everyone, I'm David Miller. I'm a Senior Public Health Officer at Birmingham City Council. And as Lauren said today, I'm going to be talking about blood pressure, and it's one of the toolboxes for the Birmingham Measurement Tools webinar series. We're scheduled for an hour, but I think realistically this will probably be more like about 20 minutes or so. Okay, so a little bit of introduction, first of all, to set the scene. Impact and outcome measurement should be a key part of any intervention that we deliver in public health. As the paragraph below says, measuring the impact of what we do helps us to demonstrate that what we're doing is making a difference, and they help us demonstrate that an intervention is having an impact in a measurable way rather than using just stories. This isn't to say that stories or case studies aren't useful. It's much better really to have a quantitative aspect too, and both ideally. Using standard tools allows us to compare different interventions' impacts, and combining these standard measures with standard questions on people's identity helps understand if different interventions are more effective for different groups. This is really important because we're very much aware that some groups within Birmingham are more at risk of certain health conditions and therefore require to some extent a targeted approach when we deliver interventions. In terms of the questions, we can also combine them with information on the cost of an intervention and the numbers of users to look at cost effectiveness also. Obviously, the more cost effective an intervention, the better really, because that adds to the case for it being funded. As it says at the bottom, without clear impact and outcome measurements, it is difficult to support funding for interventions or to justify that the approach used should be continued or scaled up. So it was like this morning, I'm afraid. My laptop's being quite slow to let me click through the slides. Okay, so on to a bit more about the Public Health Measurement Toolbox. The Public Health Measurement Toolbox has been developed to standardise impact and outcome measures for interventions that are trying to improve health and wellbeing across Birmingham. So it's something that's been designed specifically for Birmingham providers and Birmingham citizens, so it's quite bespoke in that respect. The toolbox supports organisations when they're developing projects to build the appropriate measures into their service design. In the past, we've seen varying degrees of robustness with interventions and the measures that they've been using, but hopefully us providing these measures and there being an element of standardisation should be really positive to make sure that the interventions across the board are doing this really well. It provides clarity and transparency on how to clearly assess and measure interventions based on their focus, which can then be demonstrated clearly when applying for funding. It also allows for accurate and meaningful comparisons between different programmes and interventions to help inform decision making. This is obviously incredibly pertinent because we're really keen that any spending that we commit to has as positive and strong an impact for Birmingham citizens as possible. So we've got the contents here, gives you a bit of an idea of what there's going to be in this presentation. As it says at the top, the toolbox is a developing set of resources to support measurement related to different areas of health and wellbeing, including physical activity, smoking, mental wellbeing, high blood pressure, that being obviously the one that we're doing at the moment. A couple of others there as well, as you can see, relating to sexual health. For each section, there is a description of the issue, links for local or national information on the issue, a description of the tool, information on any registration requirements, useful links to support behaviour change, and also a case study example of using the tool in practice. Okay, so on to the blood pressure toolkit, which is obviously what you're here to hear about today specifically. So first of all, a little bit of background in case anyone needs it for blood pressure. What is blood pressure? Blood pressure is a measure of the force that your heart uses to pump blood around your body. High blood pressure, so that means more force, is often related to unhealthy lifestyle habits such as smoking, drinking too much alcohol, being overweight, and not exercising enough. If it's left untreated, high blood pressure can increase your risk of developing serious long-term health conditions, including coronary heart disease, and also risk damaging the blood vessels in your kidneys or eyes. There are unfortunately a number of other conditions that it puts you at greater risk of, but I've just highlighted a few key ones here. So national and local context, around 1 in 3 adults in the UK has high blood pressure. So in England, this is 31% of men and 26% of women have high blood pressure. So that's quite significant in terms of the percentage of the population. And as the statistic below shows, a lot of that is undiagnosed. Estimates suggest that more than 41,000 people in Birmingham and Solihull have undiagnosed high blood pressure. So, you know, by providing this toolkit and raising awareness of the need to measure blood pressure and potentially take action, we're hoping to bring down the numbers of people for which it's undiagnosed and for which they're at increased risk by not receiving treatment. If you are from an African, Caribbean, or South Asian background, you are at a higher risk of developing high blood pressure than the rest of the population. So that's quite a key thing to note. We're keen that these communities are, specifically targeted in terms of improving their health outcomes relating to high blood pressure. We have got a project in Birmingham at the moment where we're trying to address this. Also, it's really important to note that blood pressure tends to rise with age. This isn't to say that younger people don't have high blood pressure at all. It is possible, but it's much more often the case for older adults, or at least prevalence increases for older adults. So as you can see here, up to 5 out of every 100 16 to 24-year-olds in England have high blood pressure, but by the age of 65 to 74, more than half, 58%, have it. Measuring blood pressure. So high blood pressure, also known as hypertension, can increase your risk of developing serious problems, including the ones I mentioned earlier, also heart attacks and strokes if it's not treated. However, high blood pressure rarely has any symptoms, which is why it is called the silent killer. The only way to know you have the condition is to get your blood pressure measured. High blood pressure can be treated through lifestyle changes or medication or a combination of both. So, it's really important to note that the reason we're keen for diagnosis rates to be improved is that, with lifestyle changes or medication, there's the opportunity to do something about it, and it is to some extent reversible. So that's really what drives us and motivates us to make these diagnoses and also provide lifestyle advice and ensure that people access appropriate treatment. It's also here worth noting that taking blood pressure readings needs to be delivered by trained professionals. We're not asking providers to, unless they're already doing it as part of their intervention and using trained professionals, we're not asking them to do blood pressure measurements themselves. What are we aiming to measure in the tool? The outcome we are aiming to measure with this tool is an increase in the number of adults who know their blood pressure and understand their cardiovascular risks. It's as simple as that, really. We want greater awareness of blood pressure numbers. So there's a great campaign called Know Your Numbers, which is relating to this, and also understanding their cardiovascular risks so that something can be done if their risk is high to address this. If we see improvements through this tool and the data collected, we would have evidence that we are tackling health inequalities. That really is, the crux of what public health is about, and it's something that we can do through this approach to blood pressure. So a little bit about the tool itself. It is a blood pressure questionnaire. There's a web link for it, and it includes the following questions. When did you last measure your blood pressure? Have you recorded your blood pressure measurement and registered it with a GP or pharmacist? What is a healthy blood pressure for an adult? Why is high blood pressure dangerous? There's no cost associated with this using this tool, and it's through a self-completed questionnaire. In terms of the frequency, we ask that the questionnaire is provided to service users at 3 points: once pre-intervention, then post-intervention, and then also 6 to 8 weeks post-intervention. This enables us to track the impact that the intervention has with this specific questionnaire and aspect of health. The ambition is also written there, which is more individuals having a measurement and having it logged, and also more individuals being able to describe a healthy blood pressure range and be aware of the risks associated. I've also included a link to benchmark data, which is the Office for Health Improvement and Disparities Fingertips Cardiovascular Health page, which has some really useful information on this topic. So using the tool, the question should not be modified in any way during implementation. This is really key because we need to be able to make that comparison across different interventions that are using the same set of questions. But there are different ways of asking the question, and this needs to be tailored to the intervention or setting. So one way would be to ask the questions face to face with someone asking the citizen the question out loud. This might be the best approach, for example, when we have service users who need additional help, for example, those with learning disabilities. The downside for this approach is that it can be overheard potentially, and therefore you need to think a little bit about confidentiality of the setting and environment. It will also require manual inputting by the person asking the questions into the data collection system. The other possibility is a self-completed questionnaire on paper or digitally. This is quicker and perhaps easier. However, the downside is that the individual may have questions about the questions, and it could be harder for them to ask those questions. And also it relies on them having digital access. Specific risk and issues to consider. To increase the rates of questionnaire completion, we ask that providers should explain to users how their data will be used and why it is important. Ideally, this should be done from both an individual and public health perspective if possible. In terms of an individual perspective, I think that's mainly around giving them the confidence that they can be trusted, or the providers can be trusted with their data. And from a public health perspective, that's giving a little bit of context of why them completing the questionnaire should ultimately have an impact on health outcomes for themselves and other Birmingham citizens. To promote digital inclusion, providers should, if needed, support users with accessing the questionnaire. Clearly, not all users will have smartphones or internet access or whatever else they need. So it's just doing what you can to facilitate them being able to access the questionnaire. I've also mentioned at the bottom here that there are language issues potentially, and support should be given where possible. So this could come in the form of if there's someone else within your provider's delivery team who is able to speak their language, getting them on board to assist, or alternatively, you could use software such as Google Translate if that helps get past that language barrier. How to report the findings. Providers should ensure that questions are the same as the toolkit. As I said before, that's really key for comparison across interventions. Providers should collate the results for each value to give a clear understanding of intervention demographics. And providers should state the values given for any participants who answered other. The last point is that in cases of small sample size, please use small number suppression in any reports to keep the results confidential. This is important because otherwise there is the risk of identification of individuals, which is not what we want in terms of data protection and isn't necessary, basically. Okay, so finally on to a case study of an example hypothetical intervention that could use this toolkit. So for example, if we had a walking group set up for older adults in Birmingham to increase their levels of physical activity and also increase social capital for them, that just means making sure they have more people that they're connected to and reduce loneliness and hopefully improve their health in those ways. Delivered over a defined period. I put 12 weeks, for example. So this intervention, it wouldn't necessarily be specifically about blood pressure. Most likely it wouldn't. However, we're likely to have a number of older adults who are service users for this intervention, and therefore it makes sense to be using this toolbox and making sure that their awareness of the importance of blood pressure, knowing it first of all, and then doing something about it if it's high, is recognised. So I've got a few additional resources listed there. A couple from the NHS, one from BSOL Healthy Hearts. That's a really great website. So I recommend that if you want to look at it yourself or share it with any service users. Blood Pressure UK and Public Health England Health Matters High Blood Pressure.